I'm Stephen Morrissey, Managing Editor of the New England Journal of Medicine, and I'm talking to Elliot Israel, Director of Clinical Research in the Pulmonary Division at Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School in Boston. We're here to discuss the benefits and risks of long-acting beta agonists in the treatment of asthma and chronic obstructive pulmonary disease. Dr. Israel, let's begin with the basics. What are long-acting beta agonists, or LABAs, and how do they work?
So long-acting beta agonists are a type of therapy used for asthma and COPD that works primarily by relaxing the airway smooth muscle. So if we think about the defect in asthma, we think about airway constriction. Part of that airway constriction or narrowing is due to the fact that there's smooth muscle constriction, and relaxation of that smooth muscle constriction can produce benefit in terms of increased airflow. In COPD, there's a problem with decreased airflow, and in that case as well, dilating the airways by relaxing the smooth muscle around the airways also can produce benefit in terms of decreasing the restriction to airflow. Long-acting beta agonists are a version of beta agonists, which are medications that work at the beta-adrenergic receptor, which are on smooth muscle, and stimulation of those receptors actually causes bronchodilation or relaxation of the muscle around the airways, allowing the airways to enlarge.
What are the benefits of LABAs for patients with asthma and patients with COPD?
Some of the benefit is the long-acting nature of these agents. They produce a more continuous relaxation of the smooth muscle. And so in comparison to using an agent every 6 hours, as a short-acting beta agonist, when they were looked at and compared to the longer-acting beta agonists, which produced relaxation for 12 hours, patients were noted to have report less symptoms and decreased work of breathing when they used long-acting beta agonists, as opposed to having that up and down, if you will, from using the short-acting beta agonists. And plus, there's obviously the convenience for the patients of not having to use an agent every 4 to 6 hours, as opposed to being able to use an agent twice a day, which fits into people's routines much more easily.
How would you prescribe LABAs? For what types of patients and under what conditions?
So I think that varies based on disease diagnosis. I think it really is different for COPD than it is for asthma. And I'll start with COPD because I think that's easier. In COPD, long-acting beta agonists produce relaxation of the airway smooth muscle. They decrease airway resistance. And clinically, they've been found to be effective in terms of decreasing symptoms for patients with COPD. So in patients with COPD, it's easier to give them a long-acting beta agonist, and one can usually say to those patients, you should, within the first 1 or 2 times that you use the long-acting beta agonist, you should notice that there's been some improvement in your work of breathing, in your symptoms in terms of shortness of breath, and so that those agents are very effective and considered among the first-line agents for the treatment of patients with COPD who are symptomatic and have airflow obstruction. In the case of asthma, the situation is a little more complicated because while these agents do produce a decrease in airway constriction and a decrease in airway narrowing and a decrease in symptoms, there's been some concern that just relieving symptoms in asthma may not be an effective strategy or a strategy that one wants to adopt in isolation. And that's because in asthma, the airway constriction that occurs is not only due to narrowing of the airways due to the smooth muscle, but it's also due to the fact that there's airway inflammation and narrowing due to edema of the airways and inflammation of the airways due to cellular influx. And then one wants to treat that airway inflammation as well as treating the airway narrowing. And when one administers long-acting beta agonists alone, one's only treating the airway narrowing related to the smooth muscle constriction and not treating the airway inflammation. So in the case of thinking about what types of patients one wants to treat with asthma with long-acting beta agonists, the thought is that one wants to combine a long-acting beta agonist with an anti-inflammatory agent in order to be able to treat the inflammatory component of the asthma and the smooth muscle narrowing. In the case of asthma, since one wants to treat the airway inflammation as well as the smooth muscle narrowing, one is generally administering long-acting beta agonists with inhaled corticosteroids. When long-acting beta agonists were first introduced, because they're so effective in producing a long-term bronchodilation and decrease in airway narrowing, it was thought that they might be able to be used alone. However, the data suggests that although they produce a reduction in symptoms and a better sense of well-being for patients that, in fact, there might be an increase in asthma exacerbations when long-acting beta agonists are used alone because the inflammatory component of the asthma isn't being treated. And so there have been several studies that have shown that even though patients report decreased symptoms, decreased use of short-acting beta agonists, decreased nighttime awakenings when they use long-acting beta agonists alone, that they were in fact actually having more asthma exacerbations when they were being treated with the long-acting beta agonists, so that it was thought not to be an acceptable strategy to just use long-acting beta agonists alone. So the consensus recommendations, as well as the recommendations of the FDA, are that long-acting beta agonists only be used with an inhaled corticosteroid in patients with asthma. That brings us to the issue then which types of patients with asthma should be treated with long-acting beta agonists and inhaled corticosteroid. And that's a somewhat controversial area in the sense that there's been some concern that in addition to this issue of these increased exacerbations with long-acting beta agonists used alone, that there might still be an issue of increased exacerbations with long-acting beta agonists even when they're used with inhaled corticosteroids. And that's based on several large studies that were done in which patients were randomized to long-acting beta agonists plus whatever therapy they were on, long-acting beta agonists or placebo plus whatever therapy they were on. And in those studies, there seemed to be an increase in the rates of severe exacerbations, hospitalizations, intubations, or deaths in the patients who had been randomized to the long-acting beta agonists rather than placebo. Now, a significant proportion of the patients in those studies were not on inhaled corticosteroids at the time those studies were being done. But even in the patients who were on inhaled corticosteroids, while there wasn't a significant increase in the rates of these severe asthma exacerbations, intubations, or deaths, there was actually still the same type of trend of relative rate of risk of these things happening in the patients who were on inhaled corticosteroids as well. So that's really caused some concern among practitioners and amongst the FDA. The FDA put a black box warning on all compounds containing LABAs, saying that they should only be used in more severe patients, and those patients should have their inhaled corticosteroids increased and then an attempt to see if their LABAs could be removed. So in answer to the question of which patients with asthma one would treat with a long-acting beta agonist inhaled corticosteroid, the recommendations and the consensus recommendations are generally that one does not institute long-acting beta agonist therapy in addition to inhaled corticosteroid therapy until patients are at least on moderate doses of inhaled corticosteroids. So meaning that if they've not responded to low doses of inhaled corticosteroids, one might consider either going to moderate doses of inhaled corticosteroids, or one might consider going to a LABA plus a lower dose of inhaled corticosteroid. Which of those two combinations one should go to remains somewhat controversial, and I think is part of what the FDA is pushing to in terms of trying to figure out what the real risk is related to the use of long-acting beta agonists in patients with asthma. I think the area where I think general consensus is clear is that it's not reasonable to take a mild asthmatic with first therapy who's not really having a lot of problems and put them on a long-acting beta agonist inhaled corticosteroid.
Do we know why or how LABAs cause asthma exacerbations?
So we don't know for sure. There are several interesting pieces of information that suggest possible mechanisms by which one might think that these exacerbations would occur. First of all, we do know that LABAs, by decreasing the airway narrowing and decreasing the airway constriction, decrease symptoms. And so one of the concerns might be that patients who are beginning to experience increased airway inflammation, the person who goes to Antilles and Antilles has a cat and they have allergies to cat, and they actually took their long-acting beta agonist, and so they're kind of sitting there at Antilles and not feeling too bad because the airway constriction is being prevented by the long-acting beta agonist. And so whereas normally they would have been aware that Antilles cat isn't good for them because they're starting to feel that their breathing's a little heavier or they're kind of getting a little heaviness in their chest, because long-acting beta agonist is actually preventing that airway constriction, even though the airway inflammation is occurring and release of mediators is occurring, one could see how possibly one might end up not getting out of there, quote-unquote, in time, right? And therefore potentially having a more significant degree of exacerbation than one might have had beforehand. So it's kind of, I give patients the example example of, if you go in the sun and if you have put a anesthetic on your skin, then you won't realize you're burning, type of issue. So that's one thought about what might be happening in a certain group of patients who take LABAs. There is some data to suggest that in some cases, actually, there's a greater degree of airway inflammation in patients who are at the same symptomatic level when they're using LABAs and lower doses of inhaled corticosteroids, as opposed to using higher doses of inhaled corticosteroids and not using their LABA. So this is a second kind of way of looking at this in terms of saying, well, perhaps what we're doing is we're masking some of the response to airway inflammation and allowing there to be a greater level of inflammation even at baseline in these patients, and that these patients might therefore be at greater risk when they run into something that might really truly cause an exacerbation.
According to the authors of a current perspective article on the LABA Indracaterol, historically, LABAs have been developed first for patients with asthma, and then the same dose has been applied to patients with COPD. Is that the most appropriate way to proceed?
I'm not sure. I think that it's difficult to know. I think what we're realizing is that the airway constriction or the airway narrowing in asthma and COPD, we always knew that the cause of airflow obstruction was pathophysiologically different in the two diseases. I think as we develop new pharmacologic agents, we're beginning to realize that those agents might act in different ways in these two diseases, which both have a hallmark of airway obstruction, and that we're beginning to actually dissect out those pathophysiological differences. So I think where before we might have thought that might be a reasonable way to go, I don't know that I would advocate doing the reverse, saying, oh, first I'll test in COPD and then I'll test in asthma. I think we need to think about these two diseases somewhat separately and say, okay, what works for COPD, what works for asthma? If one's interested, even if one's interested only in the bronchodilating component of this, and I think that's why the first studies were in asthmatic patients, because the bronchodilating component is so much easier to demonstrate in patients with asthma. Patients with asthma have a much greater degree of airway reversibility, or their smooth muscle narrowing is much more reversible than in the patients with COPD. So naturally, the first place to look, if you were looking at an agent that caused smooth muscle relaxation, was to look in the disease process where you'd have the greatest signal, and that would be asthma. And so I think that was the natural place to first, as proof of concept, if you were interested in seeing whether you had a bronchodilator, you test it in asthmatics to see if you had a bronchodilator, and then go on to COPD and see if that bronchodilator produced effects. So if that's still the goal, if your goal is to see whether you have a bronchodilator, it probably still makes sense to test for proof of concept in asthma, but what actually happens later on in terms of clinical development and whether this is appropriate for that group of patients actually really depends on what the interaction is between that drug and the disease process and the underlying pathobiology of the disease. And I think that's why we see this difference in patients with COPD, where there hasn't been a signal of increased exacerbations, deaths, or intubations with a long-acting beta agonist, which is why we're willing to prescribe long-acting beta agonists alone in those patients, but we're not willing to do that in patients with asthma.
In your view, do the risks outweigh the benefits for either group or for both groups?
So I think clearly for COPD, it appears that long-acting beta agonists produce a decrease in work of breathing, a decrease in symptoms. These are patients who are quite symptomatic, whose quality of life is severely impacted. There seems to be little data to suggest that there are significant side effects related to LABAs, and so I think that the cost-benefit equation is clearly on the positive side for long-acting beta agonists in COPD. I think the cost-benefit equation for LABAs used correctly is also on the positive side for patients with asthma. And when I say used correctly, I think in the appropriate patients, in patients using them with inhaled corticosteroids, and in patients with the appropriate degree of severity, and patients who really need the long-acting beta agonist. So, in my own practice, I tend to move up on inhaled corticosteroids until I get control, and then add a LABA to see if I can get further improvements in quality of life for patients. But try to first see if I can control the airway inflammation. So move up to the moderate dose of inhaled corticosteroids, and if one's still not getting a benefit, consider possibly even moving to a higher dose of inhaled corticosteroids, and then adding the LABA if there's still some issue in terms of day-to-day symptoms. But what I really want to see, and what I think we all want to see, is a decrease in exacerbations in these patients. And what is interesting is when one looks at the randomized studies of LABAs and inhaled corticosteroids and adding LABAs to inhaled corticosteroids. When one, for instance, in a very large study called FACET that was published in the New England Journal several years ago, it's I think now over 10 years ago actually, when they went from low-dose inhaled corticosteroid to adding a LABA to the inhaled corticosteroid versus going up to a higher dose of inhaled corticosteroid, while the inhaled corticosteroid, or rather the LABA, produced a decrease in symptoms and asthma control that looked like it was equivalent to that of adding the inhaled corticosteroids. When one looked at exacerbations, that wasn't the case. There was not as good control of exacerbations, even though it was significantly better than the low-dose inhaled corticosteroid alone. It was not as good as the higher-dose inhaled corticosteroid, and that gets again to this issue of controlling the symptoms, but the issue of controlling the underlying pathobiology in terms of inflammation, which we are concerned might lead to exacerbations.
In a perspective article earlier this year, authors from the FDA described 6 new clinical trials of LABAs that were being launched. What's the goal of these trials?
So the FDA has been concerned about the issue of whether there actually is an increase in the severe exacerbations, intubations, hospitalizations, and deaths in patients when they use LABAs, even in the context of inhaled corticosteroids. And there have been no randomized trials of the size that would allow one to really determine whether there is really this increased signal of these increased severe exacerbations. And so what the FDA has mandated is a large set of trials done by the manufacturers of LABAs to actually address this question, in which patients on inhaled corticosteroids will be randomized to a LABA or a placebo, and to see whether there's actually an increase in the rates of these exacerbations or not with the addition of the LABA. So the goal is really to try to determine whether there's an increased rate of exacerbations in relation to using the LABA in these patients when patients are using inhaled corticosteroids.
Thank you, Dr. Israel.